Good evening, friends. I'm very happy to meet you all this evening for yet another important edition of the IGS Prime Time. Warm welcome to President, our chairman of the IGS Prime Time, and we also warmly welcome the Honorary Secretary of the National IGS.
Good evening.
Friends, we have been moving from subspecialty to subspecialty. The focus of IGS Prime Time is to highlight and showcase the best of the talent and people who have spent most of their career to a single theme or single subspecialty. IGS Prime Time recognizes the important contribution to the development of the minimally invasive surgery in a single specialty so that all of us can learn and improve from their skill sets. The theme for the day will be colorectal surgery, where we have eminent faculty joining us from Singapore. We have none other than Professor Surendra Mantu, the current president of the Surgical Society, Colorectal Society of Singapore, for which we have the honors of inviting the chairman of the IGS Prime, Dr. Deep Goyal, who himself is an eminent surgical gastroenterologist with special interest in colorectal surgery. He right now heads the Department of GA Surgery and the Minimally Invasive Surgery at the BLK Max Hospital at New Delhi. And I have the honor of handing over and inviting Dr. Deep to conduct the evening's process. Over to you, Dr. Deep.
Thank you, Dr. Kanakvel. And here we are, friends, with yet another episode of Prime Time, where our aim has always been to discuss topics which are of interest to larger audience. And as we know that in a general surgeon's practice, colorectal specialty forms an important part, and especially rectal prolapse is one of the common diseases which we encounter in our practice. And there are so many procedures available. And today, to explain about this disease and various procedures and what impact these procedures have on the treatment, we have our very own Professor Surendra Mantu, who is working as a head in the hospital of Khoo Teck Kuat Hospital in Singapore. He also happens to be currently the president of the Society of Colorectal Surgeons of Singapore. And we really welcome you, Dr. Mantu, and we are really looking forward to hear pearls of wisdom from you. And I'm very sure that our audience will immensely helped by your views on this particular common topic. Thank you very much, and over to you, Dr. Mantu.
Thank you, Dr. Deep, and good afternoon, everyone. I must thank IAGS for this kind invitation as well. I'm going to share my screen. Please let me know when you can see it. Is my screen?
Perfect.
Thank you. Well, I've been asked to talk on this minimally invasive surgery for rectal prolapse. Does the type of repair influence the outcomes? And these are my credentials. Okay, just give me a moment. Okay. I bring you greetings from Singapore, and I have no disclosures to make for this lecture. This will be the outline of my talk. I'll be talking on what is the current status of rectal prolapse surgery, what are the aims of surgical repair, and what are the minimally invasive options available. I'll be discussing some of the evidence for these options, and then we will try to see whether the type of repair influences the outcomes in a patient, and at the end, there will be a take-home message. Now, almost about 20 years back, this Madiba and Wig described full thickness rectal prolapse as formidable with clear no predominant operation of choice. And this remains true even today. Till date, we know that more than 100 operative procedures or techniques have been described. And unfortunately, the search is still on. When we talk about aims of surgical repair for rectal prolapse, we need to have three aims in mind. One is to eliminate the prolapse. The second is to correct if there is any associated bowel dysfunction. And more importantly, we need to prevent the onset of any new bowel dysfunction. And when we talk about bowel dysfunction in rectal prolapse, there are two main disorders. In about 50 to 75% of patients, they do have fecal incontinence, and about 25 to 50% of patients report constipation. So these are the two important bowel dysfunctions. We need to make sure they are not either corrected, or we do not have a new onset of either incontinence or constipation. Now, basically, there are two types of minimally invasive procedures. One is the rectopexy, and the second is resection rectopexy. Now, rectopexy, there are different approaches or techniques, mainly the anterior, the lateral, the posterior, and more recently, the ventral mesh rectopexy. But besides the types of procedures, we also need to take into consideration whether a mesh or a suture has been used. And if a mesh has been used, whether it is synthetic, biologic, or more recently a hybrid mesh, and more recently, the approach of minimally invasive procedure in rectal prolapse, whether it is laparoscopic or robotic. So there are multiple considerations when we talk about the minimally invasive options for management of rectal prolapse. I'll be discussing some of the common ones, the technique and the evidence. The first, which is commonly done, is the laparoscopic suture rectopexy, which involves complete mobilization of the rectum down to the levatus, and rectum is fixed to the sacral promontory, more commonly with sutures or sometimes with staples. And the basis of this repair is that posterior dissection causes scarring and fibrosis, which keeps the rectum fixed in an elevated position. However, the main concern with this technique is worsening or new onset of constipation, which is usually attributed to the division of efferent nerves in the lateral ligaments and subsequent autonomic denervation. Now, this is true for all the procedures which involve complete mobilization of the rectum, including mainly the posterior mobilization. When we talk about evidence for laparoscopic suture rectopexy, it's a good repair in that sense that there is no reported mortality, and recurrence rate varies from 0 to 12%. Fecal incontinence improves in a majority of patients. The reported rates are about 50 to 80%. But on constipation, there is a variable effect. It has not shown improvement in most of the studies. Rather, there is aggravation of constipation in about as high as 40% of the patients. So this is something we need to keep in mind if we are using this technique for managing the rectal prolapse. The second technique, which is still commonly done, is the laparoscopic anterior mesh rectopexy, which is also called Ripstein. It was discussed way back in 1952. And in this, after complete mobilization of the rectum, the mesh is placed around the anterior rectal wall and sutured to the promontory. But unfortunately, in literature, only 2 case reports on this procedure using a laparoscopic approach has been discussed. So we don't have much evidence to talk about. The third laparoscopic procedure, which is the lateral mesh rectopexy, it again involves complete mobilization, including the posterior mobilization of the rectum. And then 2 mesh strips are sutured laterally to the rectal wall on both sides and suspended to the promontory. There are some few studies on this procedure using a laparoscopic approach. And more importantly, modifications using the laparoscopic approach have also been discussed. The key findings from the currently available literature are: there is no mortality, recurrence rate is as low as 3%. Overall, there is an improvement in fecal incontinence in nearly 1/4 of the patients. On constipation, this technique has variable effect. It improves in some, but there is aggravation in some others. The third laparoscopic procedure, which is again still done by many surgeons, is the posterior mesh rectopexy, also called Wells procedure. Again, it involves the complete mobilization of the rectum. The mesh is inserted between the sacrum and the posterior rectum and sutured onto the rectum and fixed to the promontory. So basically, the technique is more or less similar to the suture rectopexy, but instead we use a mesh here. There are again a few studies on this procedure using a laparoscopic approach, and again, modifications have been described in the literature. And when we talk about evidence, again, very low mortality. Recurrence rate is about as high as 11%. Overall, there is a good improvement in fecal incontinence, but the effect on constipation is conflicting. In fact, new onset constipation has been reported in as high as 44% patients. And then comes the newer armamentarium in this rectal prolapse management is the laparoscopic ventral mesh rectopexy. I'm sure many of you are familiar with this, and the key technical details which differs it from the rest of the procedures is that the dissection is exclusively anterolateral to the rectum, which preserves the hypogastric nerves, parasympathetic nerves, and the lateral ligaments, and avoids mobilization of the mesorectum, where is the highest risk of damaging the autonomic nerves to the rectum. It was proposed way back in 2004 by Andre Duhour's group for external rectal prolapse. And then a few years later, the same group proposed it for management of internal rectal prolapse and ODS. Now, this is the technique I use. The patient is positioned similar to when we do a low anterior section. And these are my boat placements. And this is the shape of the mesh. You started using the Prolene mesh. And now I do some patients with the biologic mesh as well. Now, these are the key surgical steps: a peritoneal incision, which is made on the lateral side of the rectum, and it is made in a J-shaped manner over the pouch of Douglas. The rectovaginal septum and the levators are exposed, and a mesh, although this is, some people use this shape of mesh, but I preferably use a J-shaped mesh, or I call it a hockey stick mesh. It is inserted and fixed to the rectum and the sacral promontory. And finally, we peritonealize the mesh by doing continuous suturing of the peritoneum over it. Now, this is a brief video of my technique of ventral mesh rectopexy. As you can see, I start the dissection on the right side of the promontory. And you can use a diathermy or even an energy device depending on your choice. And the incision is carried deep into the pelvis. And one of the key technical steps is that you leave a bit of peritoneum more on the rectal side, because you can hold it and pull it up when you're dissecting deep into the pelvis. If you do not leave this edge of peritoneum, for one, you won't be able to hold. So you have to hold the rectum, which may cause an injury. Or secondly, you may not have enough peritoneum to cover the mesh later on. So here, this is surprisingly a male patient who had a sigmoidocele and an enterocele. And you do dissection to expose the levators on the both sides. And when you tug on this peritoneal edge, you can see that you can tug the rectum. And I use slightly modified technique because suturing in the deep pelvis is not easy. So I use tackers and I tack the mesh to the levators. We have published this technique, and it has been shown the results are same when we suture the mesh to the rectum. But when we suture the mesh to the rectum, there is a small risk of erosion if the deep bites are taken deeper. But with this modification, you practically eliminate the risk of erosion of the mesh by suturing the mesh onto the rectum. And this suturing to the sacral promontory is important. You have to be careful not to injure the presacral veins. And this is the suture which will keep the mesh in place. Now, when you suture this, you must ensure that the mesh is in a very relaxed way, and it's not like a taut band. because that may hamper evacuation. And finally, when the mesh is sutured to the sacral promontory, I use a running suture, and you can use a braided suture because it helps. You don't need to hold it, it doesn't retract back. I use a braided absorbable suture for peritonealizing the mesh, and it can be done in a continuous fashion. And at the completion of this procedure, you see this patient had a very deep pouch of Douglas, and now it's very shallow. His sigmoidocele is gone, and he had a good functional recovery, and he was discharged on postoperative day 1 with normal food and diet. Now, there are certain other advantages of the laparoscopic ventral mesh rectopexy. You can do a colpopexy at the same time. When we fix the mesh, we can also fix it to the posterior wall of vagina, which may correct any prolapse of the vagina as well. In fact, this offers an option of correcting the global prolapse of the pelvis when you use two mesh as shown in the picture. We call it double mesh fixation. You put one mesh anterior to the rectum and behind the vagina, and one mesh behind the urinary bladder and in front of the vagina, and hitch up and suture these both meshes to the sacral promontory. And this is, I think, one of the laparoscopic procedures which can correct if patient has multi-compartment prolapse. There are multiple studies starting from Andre Duhur. Only one study has reported a mortality of 1%. The recurrence rate is low, 0 to 8%. There is overall improvement of fecal incontinence in a majority of patients, as high as 93% of patients. Again, there is a improvement in the constipation of majority of the patients, as high as 75%. And the new onset of constipation rate is actually very low, 0 to 6%. Now, finally, the technique of resection rectopexy or Frackman Goldberg, which is more common in the US, described way back in 1955 as an open procedure, and it combines a sigmoid resection with suture rectopexy. After complete mobilization of the rectum is elevated, and sutures are placed prior to the bowel resection and tied after the colorectal anastomosis is done. Now, it's recommended for patients who have a sigmoidocele or a very redundant sigmoid and have significant constipation. The published literature shows, again, there is a risk of mortality because you do have to resect and do an anastomosis, and it has one of the highest mortalities of as high as 6%. The recurrence rate is manageable, 0 to 11%. Overall, there is a very good improvement of fecal incontinence, but constipation again has a variable effect. It improves in many, but you have new onset also in many patients. Now, the question which is the question of this talk, can we compare the outcomes, or can the procedure or type of procedure outcome influence the outcomes in a patient? Now, in my opinion, the patient factors and surgical procedures for rectal prolapse are too diverse and complex for a simple database analysis and comparison. Now, we not only have the surgical factors, we also have the patient factors to take into consideration. What kind of prolapse, what kind of baseline functional dysfunction they had. And there are multiple other factors which can influence the outcomes, including the recurrence rates and the bowel dysfunction. Some of the key factors which can impact the outcomes, again, is whether it is resection or just rectopexy, or have we used a suture or a mesh rectopexy? If we have used a mesh, which type of mesh? And for fixation, whether we use sutures or staples, if type of fixation, is it absorbable and non-absorbable? And more recently, are we using a robotic or a laparoscopic approach for doing the procedure? There has been a recent meta-analysis which cannot compare all the procedures together, but it has compared suture rectopexy with the ventral mesh rectopexy, which seems to be the preferred operation nowadays. And you can see that when patients were compared for complete rectal prolapse, it favors mesh. That means patients with where mesh was used, there is a lower risk of recurrence. And they also compared if between the biologic and the synthetic mesh. And again, they showed that there is no difference whether you use a synthetic or a biologic mesh for ventral mesh rectopexy or any type of mesh rectopexy. So there was no difference between the biologic and the synthetic mesh. So there is a comparison between some of the key laparoscopic procedures like laparoscopic suture rectopexy, posterior mesh rectopexy, ventral mesh rectopexy, and resection rectopexy. Now, this is a good table where they have shown the comparison among important postoperative outcomes. When you look at the mortality in this table, there is no difference among the type of procedures. In terms of morbidity, again, there is no difference. When you look at recurrence, LVMR, that is the laparoscopic ventral mesh rectopexy, has the lowest rate of recurrence, around 2%. In terms of fecal incontinence improvement, LPMR, or the laparoscopic posterior mesh rectopexy, has the highest improvement. In terms of constipation improvement, LVMR scores over others procedure, and new onset constipation, LVMR has the lowest risk of about 3%. So if you look at this table, I would say clearly the winner is LVMR, and which is the preferred procedure by many European and surgeons from across the region. Um, some years back, we did compare the laparoscopic and the robotic VMR. We found some of the key findings from this study was there was a longer operating time with robotic ventral mesh rectopexy, but there was less blood loss. But more importantly, we're looking whether there's an improvement in the functional outcomes. And we did show that there was some improvement in ODS scores and in rate of anal digitation, straining, and satisfaction after defecation. And we did attribute, although theoretically, that better dissection, better preservation of the nerves could impact on the improved functional outcomes with a robotic approach. But again, this is a very small study, and we still need to have more randomized controlled trials if we want to find that robotic approach is superior to the laparoscopic approach. Now, in summary, I would say that definitive conclusions on advantage of one procedure over the other is difficult to draw because there's heterogeneity in number of factors like absence of uniform assessment of bowel function both pre and post operatively, not only among the centers but world over. There's a difference, availability of multiple surgical techniques, and people are trained in different techniques, so they tend to use the same technique. Variation in terms of use of mesh, type of mesh, sutures, and type of sutures. So we need something like multi-institutional randomized trials with longer follow-up if we really want to compare and see whether any procedure is superior to the other. An individualized approach would be recommended for every patient considering the age, comorbidity, and the underlying anatomical and functional disorders. So I would say that mastering more than one technique is useful. You may master one technique, but in some patients you may have to use a different technique. So maybe one or two techniques in our armamentarium would be very useful in managing the variable patients. And as I said in the beginning, the search is still on, and hopefully in future we'll get better answers for this very important problem. And with this, I will conclude my talk and thank you for paying the attention. Thank you very much.
Thank you, Dr. Mantu, for such an extensive description of such a complex problem where there are so many options available. As you mentioned, that more than 100 techniques are available. And obviously, then one has to be very careful looking at the pathology of the disease and which particular procedure is going to fit a particular patient. I think that's very, very important to choose the right procedure for the right patient. Taking the privilege of asking your first question is that I personally think that in some cases, though the topic today was abdominal procedures, that, perineal procedures like Altomeyer's sigmoidectomy is a very, very effective procedure for, elderly patients where, probably they are not fit for an abdominal procedure, and they really give very good results.
Yes.
What's your
Yes, I agree. In fact, my concluding line was that you need to master more than one technique,
Absolutely.
because the topic was on minimally invasive, so obviously it has to be abdominal procedure. But absolutely, you're right. Perineal procedures are still being used, and I would say sometimes more commonly used in certain centers where the facilities, not only about the fitness of the patient, sometimes you don't have the facilities of a laparoscopic or mesh or ventral, or the expertise is not available. And perineal procedures, I would say, are easier to master. But what is happening over the years since the introduction of the laparoscopic ventral mesh rectopexy and better perioperative care of the elderly in European circles, more and more patients are being offered abdominal procedures. In fact, if you look at the literature, there are many papers where they have indicated that abdominal procedures are safe and with improved outcomes in even in elderly patients. But I again agree to your comment that we must be ready to offer a few more options than rather than only one option to our patient.
And what is your view about? I am personally a great fan of doing a resection suture ectopexy, especially in patients who have a constipation predominant symptoms, and on imaging we find significant redundant colon.
Yes.
These are patients we really do resection ectopexy, and there's a huge
Yes,
benefit.
if you document on imaging or a dynamic MR or even a CT scan that they have a redundant sigmoid and the predominant bowel dysfunction is constipation, you can offer a resection rectopexy. But again, rectal prolapse is not a malignant disorder like a cancer where you have to do resection, because resection comes with its own risks, especially the anastomotic leak, which is a dreaded complication for any colorectal surgeon. So you have to be mindful about the anastomotic complications. But if you have kept your anastomotic leak rates very low and you have the expertise, yes, there is a role, and it is more commonly practiced in US, where they combine the resection and rectopexy together for their patients.
Yeah, we do this quite common. In fact, in my practice, I think the section rectopexy is almost equal numbers as compared to other
Yeah.
forms of.
Again, you if you have kept your complication rates very low and the expertise is there, yeah, it can be offered to the patient.
Dr. Kanakbel, anything you
Yes, sir. Thank you, Professor
Dr.
Mantu.
Surendra,
I think it's one of the very robust data-driven talk which I've ever heard in the recent times.
Thank you.
And the one recent network analysis goes on to conclude in one line. At this point of time, with due consideration of all the procedures, the posterior mesh rectopexy seems to be the more least complications with the procedure, and that is what is uh, probably the number of years posterior mesh rectopexy and the amount of things should have skewed the data towards that side from the ventral. I have two quick questions. All of us are always worried when we see the patient whom we have operated 2 years before, 3 years before, or coming for a consult. At times, we are appalled to see they land up with either partial prolapse and sometimes they land up with sort of a totally obstructed rectum. Uh, Many times it happens much later than the primary surgical care. So, what is your experience on revision procedures? Say, for instance, if you can quickly tell up how do you work
Yes.
this patient up, and then what is the ideal option you give them as a remedy for this problem?
Yeah, this is a problem, because it's a long-term issue, and it's mainly related to the collagen disorder. Rectal prolapse is just like a hernia, because these tissues are weak. No matter what kind of repair, there's always the risk of recurrence, especially if you follow long term, because there's follow-up at 10 years and you will see patients with. So my principle is that if I use an abdominal procedure and if I use a mesh, you can imagine it is very difficult to redo a procedure through an abdominal approach. So you should approach it transperineally. That's why I always tell everyone that you should have more than one techniques in your armamentarium. If you have done the perineal procedure, then you can very well think about doing an abdominal procedure. So that should be the principle. If you have used one route, you should then explore the other route, especially if you have used a mesh. Um, in certain cases where you can selectively choose an abdominal, if you have the expertise, abdominal approach again. Um, but my principle is, if I've done it abdominally, I've used a mesh and patient has a recurrence, I will use the perineal. I will do either an Altmeyer's or even DeLorme's.
And one other complication, many times at least I have not seen one from my series of patients, but then I've had the occasions to manage patient coming back to tell the mesh is jetting out of the rectum, something foreign feels down when they push down motion. Then becomes a challenge. On at least one occasion, we could just gently tease out the mesh in full. But many times it becomes a huge challenge that we end up having trouble of multiple procedures to remove the
It,
mesh, which is
It
what
is
is
a
your experience
nightmare.
on that?
Yes, it is a nightmare. Fortunately, I didn't have to do any of my patients so far, but it is a nightmare. I trained in France. I did see some patients there because it's a referral center for all over France. So you did get patients with mesh complications. I think that's one of the reasons that people are still exploring non-mesh or even biologic mesh options. Biologic mesh options, eventually they will integrate with the tissues and there will be nothing left. So many, in fact, my center where I trained, and in fact in my practice also, I have switched from the synthetic to a biologic mesh. And the very reason is that. And the second reason for that is because most of these patients are in the same age group of the risk of having rectal cancers. If you have a synthetic mesh, you have to do an anterior section. It can be very, very challenging. That's why you need to thoroughly investigate these patients, have a colonoscopy, and rule out, make sure there's no malignancy in the colon or rectum. Biologic mesh gives us an option because after a while you can cut on these like a normal tissue. So if there's an option available, I think biologic mesh is the way to go. Although there is no difference in outcome,
Dr. Mantu, correct me if I'm wrong. As per my understanding, wherever biological mesh has been used, like in say hiatus hernia, it is shown that in long term the recurrence rates are higher. I'm not sure about what does literature say about rectal prolapse.
I mean, biologic mesh have been used for this only for last, I would say, 5-6 years, and not a long follow-up. So far, the early outcomes are similar. That's what the meta-analysis shows. But you are absolutely right. We need to be careful about that. But we not only depend on the mesh, we also depend on the fibrosis it creates, and hopefully it will hold the rectum in an elevated position, and we don't see many recurrences. But yes, that is something we need to keep in mind.
Thank you.
And one last question from my side. Uh, is manometry a requirement for all your patients, either primary or secondary, or you choose selectively to subject these patients?
I do not do manometry routinely, but I do an ultrasound routinely. Ultrasound to see the anatomy of the sphincters, especially if patient complains of fecal incontinence or leakage or this. But because ultrasound I can do it myself, so I do it routinely for them. It's a part of pre-operative workup. It gives me you can counsel the patient better, and it also helps me what would be the function after the surgery, expected function. So I do warn all the patients that there can be worsening, and that's one thing you need to remember when you do perineal procedures. Perineal procedures, always the risk is worsening of the continence. That's why people have moved to abdominal. There are so many things, so many complex factors come into play when you have to choose an option for a patient. What is the baseline function? Is it more incontinence? Then you would want to do a abdominal procedure. But ultrasound, I do it myself. It doesn't take much time. I do ultrasound. Manometry actually is not very, very helpful. Even if you show low pressure, it doesn't change anything in the management. We still need to correct the prolapse.
One last question. We at times come across with hernias and rectal prolapse together. If that is a inguinal hernia and a rectal prolapse, what will be your choice procedure?
If you have to do both together, I would like to do a stage.
Would you do both together?
Preferably
First
not.
question is that. Okay.
I mean, this is a very common scenario. We have colorectal cancer, then we have a hernia. We never do it together. So,
okay.
Take principle, especially if you're using a mesh, you wouldn't, do together. But if you have to do together, if patient wants it, then you would do a suture rectopexy and hernia repair, or you can put a mesh. So okay, now the important thing is which procedure to do first. You must do the rectum first, because in the rectum there is always small risk of making an injury to the rectum, so there will be contamination, and that affects the hernia procedure. You never do the hernia first and then you do so that you need to keep in mind.
So Dr. Kanagwe, just to make a comment on that, if
yes,
you're choosing to do a perineal procedure, don't do it together. If you're doing a resection rectopexy, don't do a hernia together. If you're doing a procedure where you're not violating the viscera, then as Dr. Mantu said, do the rectal prolapse surgery first and see everything is fine, and then you can do the hernia in the same setting.
Perfectly understandable, sir. Can we hear the comments from Dr. Mida, and then we move on to the president?
Dr. Surendra, how do you pre-operatively prepare your patients and post-operative care so that there is least chance of recurrence?
Yeah, I think that's a very good question. First you need to do a workup to rule out any disorders like cancers. You need to do a full colonoscopy, and if patient has incontinence, I do an ultrasound for that. But what is more important is the patient counseling. You need to manage the expectations. We know that these procedures, that's why there are hundreds of procedures, and the search is still on. There is no procedure which can guarantee 100% success for the patient. You need to warn that it is something related to your body, your collagen tissue, and there's a risk of recurrence. But if we do the right procedure, the risk will be minimized, but not eliminated completely. So counseling is one of the most important things, which patient will, if patient understands, it will avoid medical legal litigations, and it also brings confidence of the patient for the surgeon. In terms of how to, basically you need to have a good technique. You need to do an imaging, preferably a dynamic MR, and that is to rule out whether there's a concomitant middle and anterior compartment prolapse. Because if you repair rectal prolapse and you have not investigated for a urinary bladder prolapse or a vaginal prolapse, they are manifested. So patient will come back to you with urinary incontinence, which was not initially there. So you need to do a good, history taking, assessment of the urinary function, vaginal prolapse, do a good clinical examination to assess for any prolapse, and do a dynamic MRI if it is available, because dynamic MRI will allow you a global assessment of the pelvic floor. And if you see concomitant, then again, if you have the expertise available, the advantage of laparoscopic ventral mesh rectopexy, if you have a urogynecologist, you can do a combined repair together, which will avoid patient a second surgery and give better functional outcomes. But if you don't have, then you need to warn the patient that, okay, rectal prolapse may be corrected, but it is possible you may end up with urinary, incontinence or other problems.
Thank you, Dr. Mantu. Now we can move on to the next
President,
talk.
Sir. President, sir, your comment before we, Dr. Mantu would like to recuse himself for the networking dinner, which is happening. So,
no, fully understand, Professor Surendra. It's really enjoyed the talk. It is very crisp, and I mean comprehensive with all the lot of evidence. So just want to see, because rectal prolapse, I think it's in my perspective from everyday surgeons perspective, it is not a common thing we do, not like hernia and things. So do you think this is one, it has to be done in a high volume center where there is a team which evaluates and prescribes the tailor-made for this patient of this particular profile, risk profile, this may be the ideal one. I mean, it's a lot of discussion. I think the execution is a part, but before that, a lot of things are happening. I just wonder how.
Absolutely, you're right. These procedures, the numbers are not big, so they should be managed in a high volume center where you have preferably a multidisciplinary team, where you have a urogynecologist, you have a colorectal surgeon, you have other people, like people who can give biofeedback and have other facilities available. Otherwise the results will not, if you do one a year or two a year, the results are not going to be good. And this is not true for this procedure only, it's true for most of the procedures. It has been shown in evidence, the more you do, the better you get. And rectal prolapse is no exception to that. So yes, it has to be managed in a high volume center where you have the expertise not only of the colorectal surgeon but beyond that as well.
Thank you for having joined in the midst of your other academic deliberations. I think you have a very enjoyable banquet today, and we'll continue with our academics for the next 20 minutes or so. Over to you, Kanai.
Thank you so much.
Thank you, Dr.
Thank you.
Thank you, Mantu. Please feel free to excuse yourself.
Thank you so
We
much.
look forward for more academic
Yes, of
collaborations with the Singapore Society.
Of
Our
course.
president is always keen in forging new relationships to improve the academics
I'll be happy to
collaboration.
initiate. Thank you.
Thank you, sir.
And we also have our national conference coming up. We will be happy to have you on board with us to contribute.
Thank you.
And Chennai is the 2.5 hours flying for you from
No
Singapore.
problem. Yeah, Chennai is the nearest place for Singapore. No problem. Thank you so much. Thank you.
Thank you very
You
much,
all have a
Dr.
good
Mantu.
evening. Thank you.
Thank you very much. Friends, we move on to the section B of this evening's program. Colonoscopy and endoscopy should always be a part of a surgeon's armamentarium. Our president bats for it very robustly. And today we have the honor of having him speak to us on top 10 tips for colonoscopy. Before that, we'd like to have an update about what is happening in the IAGS and what are his plans for the coming month. Then we move on to the talk. Over to President, sir.
Thank you, Kanajavel, Deep, Satish, and our guest speaker, all my faculty friends across the globe, and my dear viewers in this Doc Plexus platform. It's indeed a great pleasure to be with you today, and it's very, very heartening to see already from going across the countries, more and more people are willing to take this endoscopy training and colonoscopy training in a big way, and gives a lot of motivation for trainers like us to do more. So I thought I'll just summarize, because pertaining to the colorectal topic, and as a surgeon, you should be all doing colonoscopy. There is no doubt about it. You're all legally permitted to do colonoscopy. That's where I start making. But let us give some advice how you can make your colonoscopy better. Because we see there are already prevailing quality indicators. When I say, whenever you perform, you try to take your time, try to reach the cecum slowly and steadily, at least most of the time. Because it's very important in a screening to have not to miss even a single polyp, what we call a polyp detection rate. It has to be 25%. That is, every fourth patient, there will be a small sessile polyp lurking somewhere in the right side colon, which can be easily overlooked if you are too fast taking this scope out. That's why we have another important quality indicator. The cecum, once you reached, come very slowly, at least take 6 minutes or more to come into the rectum. And of course, when you do that, there are two important things. Always keep the lumen under view. Never use undue force, so that you have a zero tolerance to the risk of perforation. So in order to have all this good quality control, you need to master the technique. Let me share with you, there are plenty of tips and tricks from a lot of trainers. Let me give those 10 I think is pertinent to today's discussion. One, of course, all of you will agree with me, is a good bowel preparation. Because I always say, if you have a patient whose bowel is well prepared, it is so clean, then you can walk through the bowel. It is halfway to the success, I would say. So you have to stick to one bowel preparation which is good in your setup. In my opinion, I think polyethylene glycol, unless contraindicated because it is isotonic, even though it is not very tasty, 2 liters very often the adults don't mind taking it, and you give it in the morning, 2 hours they let them take to drink, and another 2 to 3 hours you wait until they purge several times, and you ensure your staff talk to the patient cleanly that they have had the bowel so clean then they are ready to be on the table. So this is have to be verified. Otherwise, you don't want a patient sedated, then find a sorry state like this, an unprepared bowel. So we always have a quality control. In every case, I write Boston bowel preparation score, something like a Glasgow coma score. You need to see when you go navigate the left side colon, transverse colon, and the right side colon. See whether the bowel is so clean like this, like as if you are doing an upper GI endoscopy, or a little fluid inside, which is not entering you, just till you can suck and go, or is it liquid feces or a solid feces, both are unwelcome. And if this state is there very often, either you may have to abandon the procedure there, or you need to tell gross lesions only you can see, and subtle lesions can be easily overlooked. You have to mention and document, and it should not happen again and again. So this is all about the bowel preparation, I would say. But sometimes patient says, after completing this, they will ask you, what else? Doctor, I am still feeling thirsty. You can ask them to take ORS fluid, tender coconut, green tea, nothing more. So if they can take, they can feel okay, at least 1 hour before taking them to the colonoscopy shoot. The second thing I always say, especially when I go to some lot of teaching institution where it is always a two-man army. That is, one person will be doing, the other person will be pushing and pulling. But I think the best way you learn yourself is unlearn the bad habits, learn this way. You have your right hand doing the talking, the right hand torque steering. In other words, you don't go like this. You need to go like this. You have to torque steering slowly and steadily. That is the way, because the colon is winding a road. So you need to be take the full control. Your left non-dominant hand takes the control head, big wheels, small wheels, and all the buttons. And right hand just about 10 centimeter from the anal verge. It is as if you're holding a pen. Don't hold it like as if you're holding a tennis racket. So these are all very important tricks you should learn. As I said, the torque steering, I would say probably you have to imagine as if you're sitting in a car, not in the front seat, actually rear seat, and trying to drive. That is a steering. Or as if you're driving a screwdriver. The screwdriver movement is like a spirus action. So it will slowly drive the scope more to this clockwise twist. So that will avoid the alpha loop formation. This is another way of avoiding alpha loop formation. And you need to make sure you are having a baseline table, straight line monitor, and you have a good grip, and you should have all the universal precaution. So these are all essence of the ergonomics. So make sure you make your life easy. Easy in the sense you are very efficient and you're comfortable by adapting this particular methodology. Sometimes we have 2 screens, one for you and one for your staffs, like what we do in advanced laparoscopic procedures. The very important trick I would say is take your time to go through navigating the sigmoid. I think the sigmoid navigation is the key to near success. If the bowel preparation is half success, this will take you most of the time. Because if you carefully see this picture, sometimes when you go into the sigmoid, it will, as you insufflate, become very tortuous. And you are going from a pelvic sigmoid to the intra-abdominal colon, then again coming to an area where the mobile colon becomes a fixed retroperitoneal descending colon. The sigmoid descending upward push is going to be the challenging. You form what is called classical N loop. So this is the problem. So if you're clever, if you are able to understand how to avoid that and how to rectify that, then you will be the master of colonoscopy. So there are few things I wanted to tell you, which we may know already. Just when you go, you treat each monitor you see, every monitor you have, like a clock. So if you see here in this, you have this darkness. Wherever there is a darkness, that is the likely lumen, here around 7 o'clock. Or where the direction of the longitudinal fold, the tinea coli, That shows you need to go towards the 12 o'clock. There you need to bring the big wheel towards you, then you start looking up. So you need to know which wheel and how to torque, and this over a period of many of hundreds of upper GI endoscopies you have done before you venture into the colonoscopy. Because I used to say colonoscopy, like colonoscopy is having a longer, it is not only the scope is longer, the learning curve is also longer. So you should take your time to master this. 150 cases ideally one has to do, either assist under supervision or do it independently. So you get these clues to navigate. Always you try to get the lumen somewhere on the center or to the top right corner. If you do that, then naturally you'll be going in this direction. Because if the lumen is somewhere here, then you tend to go anti-clockwise. Once or twice you can do, but try to turn. This way is the colon, and you start doing, if you imagine the axis of colon is winding, if you start rotating it clockwise, then the colon will be in alignment, as if this all the CD discs are in alignment. So this way you can align. So this is a very classical example. So you see, this is the way we navigate. Take your time. Don't push very fast. Slow and steady wins the race. Clockwise. See, this is the clockwise rotation. You can see it is occasionally anti-clock. See, this is a little anti-clockwise because the lumen is more towards the left. Most of the time, you do clockwise rotation. In no time, you'll go to the sigmoid descending colon, and that is what you need to achieve. So if you get the sigmoid intubation right, then rest of the intubation would be right. So this is what but I told you, don't get upset when you form a loop, or if the patient is having in pain, or you're not able to proceed, because a loop formation is a part of your life as a colonoscopist. It is a rule rather than an exception, I would say. So there are basically 3 different types of loops. Out of the first 2 are very important. That is, one is a N loop, then alpha loop, rarely in the transverse colon as a gamma loop. N loop will form whenever you go, you make the distension of the sigmoid. Sigmoid becomes like a sigmoid volvulus. Then it goes to the fixed sigmoid descending colon. So at 40 centimeter at the anal verge, you just start pushing. Only this loop is getting bigger and bigger. You're not progressing here. So 40 centimeter trouble and patient is in pain, most likely is N loop. Whereas in alpha loop, life is very easy. You just keep going because there is no acute curve. It goes in the alpha configuration and you find it very easy. Then you start enjoying, oh, it looks like an easy colonoscopy today. But only you to realize that when you reach the splenic flexure, rough around 1 meter, it will show here. Then if you push, the alpha loop gets bigger and bigger, patient is in pain. So pain, when you push 1 centimeter or 2 centimeter, you're not getting a similar forward motion of the tip of this colonoscopy. 1:1 motion is not there. Or when you push, the colonoscopy is receding in the screen. Paradoxically, these are all the indirect evidence. There is no need for a C-arm or any other high-tech equipments to find whether you have formed a loop or not. As I said, loop is a rule. Gamma rule, loop is so rare, forget it for the time being. Let's come. Imagine you are in a N loop, which is a common one. Problem at 40 centimeter, what do you do? Don't hesitate to deflate and come back. So that is what you need to do. This is an MRI, or we call a scope guide in the colonoscopy. We'll have a PAP, we have a high-end colonoscopy like 190. And if you see the big loop, pull, don't hesitate. It will come around 20 centimeter, it will come. At one fine moment, you will see the sigmoid is straightened and the whole sigmoid is swallowed by a small portion. Then you will ascend in no time to the descending colon. You start seeing the fluid level. When you fly over the fluid level, that means you are on the descending colon. So this is the configuration. From this configuration you need to achieve for that no hesitation coming back. The second problem, as I said, the problem at 1 meter, that is, you formed a nice alpha loop and you're stuck at the splenic flexure. You push, patient is in pain. If you know that the problem is at that level, what you need to do, if you see the configuration, you need to do a clockwise right torque, pull back. Simple pullback will reduce the N loop. Clockwise torque and pullback will reduce the alpha loop. That's why I'm telling you, I used to do upfront, preemptive clockwise rotation to prevent the alpha loop in most of the situation. N loop is the one we need to see it when it happens. Yes, alpha loop can be prevented, but even if it happens, we can always reduce it. It is now clockwise. I'm doing it, pushing. It is back in a straight mode. Now you can jolly well go. But loop once formed doesn't mean it will not reform. As you go further in, it will form again. So repeated pullback, repeated reduction is the order of the day. Whenever you don't have this 1:1 movement. The markings are important. In endoscopy, I can tell if I'm at 40 centimeter, it's an OG junction. If I am 60 centimeter, I can tell I have seen the ampulla. The marking in the colonoscopy and where you are, there is no signpost in the colonoscopy. Take it from me. People have done a wrong operation sometime, thinking that there is a tumor in the transverse colon. Actually, the tumor was in the sigmoid colon. It is a tortuous sigmoid colon. So don't go by that, because a tortuous colon, you first of all, you need to reduce, make it like a question mark, like this is a taut colon. This is the tortuous colon. If the colon is taut like this, then the rectosigmoid junction should be at 15 centimeter from the anal verge, sigmoid descending at 30, splenic flexure at 40, hepatic flexure at 50, and the cecum around 60 or 70 at the maximum. We have 160 centimeter colonoscopy. All you need is a 70 or 80 only, most of the situation, but it all happens by an experience. So in short, you should not ride on the air insufflation button. That is the inferior button. You should be very, very critical how much of carbon dioxide you insufflate. Insufflated colon is a long colon. So try to suck, desufflate. That is the key to progress. So ladies and gentlemen, 2 steps forward every time you take. Prepare to take 1 step backward. That is the way you progress in colonoscopy. That is the way you get the colon straight. Because when the colon is straight only, whatever you do in the outside, it will be replicated in the inside. For example, here, if I am turn the scope clockwise, torquing it like this, if outside, the same thing I can see it inside only if it is in a straight colon. If it is already having a loop, this is impossible. See, now I'm pushing 1:1 movement I'm getting. Sometimes, if it keeps on forming a loop, there is another gadgets available in very many of the Olympus, the advanced one, that is called variable stiffness. There is a small, like a knob available below the control head, which if you corkscrew, that will tighten the whole scope. So that is called variable stiffness scope. Coming to the next tip I would like to give for the beginner, if you are stuck in some places, if your patient is in a left lateral position, you think by changing the patient's position, are we going to get any progress? It can change the fortune. See, for example, this is the position most of us will be doing. We will be standing here and doing the colonoscopy. Occasionally, especially in a young patient, young lady for that matter, who had a hysterectomy, where there is a pelvic adhesion, then you will be stuck at the rectosigmoid junction. Then rectosigmoid junction will be going acutely anterior. So there it may be sensible to turn the patient at least for momentarily to supine position, something like this, with the patient leg crossed like that. Then you can jolly well do with your left hand pushing on the suprapelvic region. So rectosigmoid difficulty, patient becomes supine. Whereas if you have a very difficult splenic flexion, then you need to even turn the patient looking towards you, looking to you. That is a right lateral. Why you do that? If you see this picture, in left lateral position, if you go, then here you have the fluid level and you have the splenic flexure very acute like this, because the weight of the transverse colon is on the dependent area. Whereas if you turn the patient to the opposite, then this is the descending colon and this splenic flexure becomes opened up. The angle is less acute. And also if you ask the patient to take a deep breathing, the diaphragm brings the splenic flexure down. So deep breathing, hold on the breath, turn the patient, suck the fluid in the splenic flexure, then you can slip into the transverse colon. So these are all the few tricks you may have to consider. Then transverse colon is mostly easy job, because the triangular configuration of transverse colon, suction as you see from one end of the transverse colon, that is the splenic flexure, to the hepatic flexure, you can walk in no time. The problem is diving into the ascending colon, reaching the cecum. Sometimes could be difficult, but you will get there eventually. And once you go there, you know what you have reached, because cecum has some landmarks to say that you have reached it for sure. There are 3 landmarks. 2 of the 3 should be always present. The bulbous or the edematous or a lipomatous ileocecal fold, that is the last ostral folds, normally seen around 6 or 7 o'clock position. Even you can faintly see sometimes the inferior lip of the ileocecal valve. So this is one lip and this is another lip. In between is the ileocecal opening, that is the ileum is there, the pose of ileum, here around 11 o'clock. Second is appendicular opening. Then the convergence of all the 3 tinea coli, that is we call the crowfoots. Don't just press the right iliac fossa. And your external pressure gives you some indentation in that region. That doesn't mean anything. Trans illumination of light in the right iliac fossa doesn't mean anything. Both are false security for you. So definite assurance that you reached the cecum is only 2 of the 3. Yeah, I would say probably all the 3. But still, at least in a screening colonoscopy, one has to be not 99% sure that you reach the cecum, 100% you reach the cecum. For that, you need to enter the ileum. Then only I believe that you have done a full colonoscopy. Is it challenging to really enter the ileum? If you say, probably for the first 50, 60 cases, reaching the cecum itself is as hard. It will be a lot of perspiration for you. But you have the target for ileum all the time. Eventually, you will get into it every time. See, for example, here it's around 7 o'clock here. You have something like a bow arrow sign. That is, you have to imagine the convexity of the appendicular opening. From there, you imagine as if you are throwing a bow. The bow arrow, that is, the arrow will be pointing, the pointer of the arrow will be somewhere towards this. Sometimes if the patient is in prone position, some people prefer actually for this in prone position, you can bring the ileocecal fold to 12 o'clock like this, and it will be much easier to enter the ileum. So ileum intubation is easy if the ileocecal valve is at 12 o'clock. That sometimes happens by an accident, but sometimes if the patient is in prone position. But even otherwise, if it is a 6, 9 or 12, if you know exactly, then you are the driver. If you have one-to-one movement, it may not be a too difficult job to enter by this bow arrow sign. See, here is a classical example. See, here is this bifid lipomatous ileocecal valve. This is the apparent direction of the ileum. So you need to go big wheel little away, then you go back, pull the scope, insufflate, then you will be seeing this very classical villi in the ileum, because this is a very important component to say that you have done a completion colonoscopy, and also very important, especially in inflammatory bowel disease like Crohn's disease or tuberculosis. So intubation to cecum is important, yes, but that is not the end of the job. The job is just a beginning, because you are so much occupied or preoccupied trying to navigate. You haven't seen a lesion. The lesions you will be seeing more on your way out, because you're more relaxed now. So you try to look up, down, right, left. If you go again, all this before in front of the ostral folds, take your time. Minimum 6 minutes, probably longer. Longer you wait, better for you to see any lesions. That's why here nowadays most of the upcoming endoscopy or colonoscopy is inbuilt what we call endobrain. The endobrain is a software, artificial intelligence that will give you a little square wherever there is some elevation abnormalities. At least that will make you think or look carefully those regions. So that will alert the wherever there is a lesion. But without endobrain, without artificial intelligence, use your own common sense, come slowly, try not to miss a lesion. Because sessile adenoma on the right side colon is a very, very important precancerous lesion. If you miss it, those cases will go in for what we call internal cancers. So you should be very, very careful. All right. Do I have any more tips if you ask me? Yes. Yet another tip I would like to share with you is, if you don't progress, pressure at the right place at the right time, it will give you the right results. What do you mean by that? For example, if you are repeatedly getting a sigmoid loop formation, especially N loop, what you do is you reduce the N loop before you start pushing the scope again, because it is again going to cause a loop. You ask your staff, to put a firm suprapubic pressure, very firm pressure with her left hand, so that she will not allow the sigmoid ascending from pelvis to abdomen. So that way, it will avoid making another loop. This should not be done when the patient is having already a loop. The loop has to be reduced before you start pushing the scope again from 20 centimeter. This pressure, for at least for the next 2-3 minutes, will make sure you go into the descending colon very easily. So suprapubic pressure is my success story in very many conditions. And I told you in the beginning itself, don't go blindly. It's like a virus needle. When you insert, you can have a leap of faith, but here the leap of faith, undue force, means always a recipe for disaster. If you want to see a disaster, look at this one, because here is a patient actually had a hysterectomy before, and she came for a colonoscopy. This is what happened. When you go for a patient with a previous pelvic surgery, the rectosigmoid junction will be fixed, and it will be sometimes very difficult to go acutely go across this. And you go and hit, and somewhere you go into outside the colon. See, the surgeon or the colonoscopist is having what you call a readouts. Suddenly he sees this unusual, like a areolar tissue, and when he withdraws the scope, to his horror, he sees a perforation. Ladies and gentlemen, take it from me, when you create a perforation during diagnostic colonoscopy, the perforation is as big as colonoscopy, that is 12 millimeter in diameter. So perforation during diagnostic colonoscopy is much bigger than during a therapeutic colonoscopy, because there it happens because of the ESD. Very often it is a small target sign. So this is very important. Unless you are well versed with the Ovisco clip or some other endotherapy, I think it is kinder and better. Immediately you go talk to the patient or relatives, get the patient onto a laparoscopic table, rectify the problem. If you wait another day, then the septic peritonitis will settle in. So the perforation can happen with the very tip or loop of the scope, or if you try to force your way through a stricture, or if you blow a lot of air into the diverticulum, or even when you put the biopsy force like a dot, the undue force trying to take from a thinned out ulcerative colitis colon, which is paperly thin. So these are the 5 common reasons why a colonoscopy can give rise to this deadly complication. Try to be very delicate. Never use undue force when you drive the scope or when you take a biopsy. So that's a message I want to. So don't rush, take it slowly, don't push it blindly. The final comment I would like to give, of course, yes, colonoscopic perforation is a very sinister. So if you are in trouble, don't persevere. Keep on trying to do a 100% colonoscopy. Incomplete colonoscopy is not a sin. You can always come another day, or you can have a plan B. Because there are umpteen number of conditions where you have a difficulty. Elderly man with diverticulitis, or a stricture, or unprepared bowel, previous surgery, young patient with irritable bowel syndrome where she winces with every time when you inflate. So there are a lot of difficult cases, but there are lots of options we have. So in other words, we need to think about plan B. Do I need to change the scope? Thinner scopes like a pediatric scope or even a gastroscope, or a different technique like instead of air, CO2, or water immersion colonoscopy is less acute. Or sometimes I have used few cases of putting a cap at the tip of the colonoscopy. It actually helps navigate. And the people will fear, will it not cause a perforation, sir? This is now sharp. It is not so. Actually, Japanese people, they do it routinely, a colonoscopy with this one. I also will be encouraging results in the initial few cases. So cap technique is one thing, not restricted to only therapeutic intervention, but also for a diagnostic success. And newer devices, like if you want to perfect adenoma detection rate to the maximum, then you need to use additional gadgets, which when it goes in, it will be closed. When you come back, all this open, it will open all the sides, so that all the hostile folds are wide open, so you will not miss any lesions. So there are a lot of avenues to perfect your art, and these are all, in other words, there is always further improvement you can do in your technique or in your technology. And also there are CT Virtual colonoscopy is always there if you want to miss any, not to miss any gross lesion, because patient is well prepared. Your CT scan room is next room. You have done an incomplete colonoscopy. Patient is anemic. You don't want to miss a gross lesion in the cecum, and you can do that also. There is a possibility, or you can send it to somebody who is much senior, or bring the patient for some other day. And also there is a small role for a capsule colonoscopy also for a situation where the colonoscopy was incomplete. It is not as commonly used like a capsule endoscopy, but it still has a role to play. So, my dear delegates and ladies and gentlemen, this is an art that has to be practiced by initially. The days are gone where you go straight to the patient. Now we have a dry lab, wet lab, virtual lab, then only live cases. Even there, see, then assist under supervision, then do plenty direct observed supervision by selected tops, then quantify. Improve the quality of the training is very, very important. It is not only just trying to navigation, that is only a technical skill. When you see a lesion, do you know how to describe a lesion? If it is inflammatory bowel disease. If there is a polyp, do you know Paris classification, kudos classification, various things. So you need to really master. So that's why the quality control becomes very important for a trainer like us. So that's why we conduct programs like EFAGS, 4G, and now we have recently successfully done a 4G colonoscopy. We learned a lot. So we are restructuring the course, making it as a long duration course, make it a credible course, and so that we get an accreditation from respectable academic bodies across the globe. So we also thinking about having more training avenues, like keeping the trainees at least few hours, like for example, the end loop, all the loop reduction, everything one can easily teach in a virtual. If you ask my trainee to spend at least 10 hours, that's a medium time. Let's say 10 hours, if you're able to spend in this one, you can see exactly how it is navigating, how you are going across the transverse, everything. Then you go. It's like a virtual cholecystectomy and real cholecystectomy. Here, virtual colonoscopy, then real colonoscopy. So that's a one way of trying to do. But never forget the setup you work, the team you develop, the tools you have. Don't underestimate the potential. Have a high-end colonoscopy, CO2 insufflator, irrigation device, good staffs, appropriate accessories makes the life very, very important. Because at the end of the day, you want the patient safety with the teamwork. So you need to have the passion, perfect the art of colonoscopy. So you have to do what you love and love what you want to do. So that's all from me, and I have 4 important announcements quickly to make. We are traveling, like I think Kanavel is not coming, but Deep is coming with me because he is returned from US. So we are going to UK for a UK Surgicon. This is going to be, and Satish also will be joining with his wife, Poonam, and Kamlesh. Everybody will be joining for IAGS RCS Edinburgh International Collaborative Conference. 7 sessions, 2 halls, and we have poster papers by various postgraduates. So I'm sure it will be a historic event. And we have also planning to have a collaborative meeting with the college. After that, we'll be seeing you all, hopefully many of you delegates. We have a midterm conference and course at Bhopal. It's actually a course I could say. We had a Tricon at Kanyakumari, where 3 events were happening. Now here, 5 events are going to happen. Pentagon, I would say. There are 3 courses, 1 business meeting, and a 2-day midterm conference in an excellent avenue. Isant, Nidhi, and the team Bhopal with H.L. Gupta as at the helm, doing a wonderful job. Please join us, and I have sent all the communication only today for you to register. Of course, Kanag will be very, very eager to see you all, along with Zamir Baza, myself, Govindraj, Sadish, all of us. This is going to be a conference you will really experience the academic at its best. We have the excellent safety innovation as our theme. A lot of international speakers are there, and we have a robust program in one of the best venue you can think of in Chennai, the Taj Coromandel. So we always say, Vanakkam Chennai, come and enjoy our Tamil hospitality. And of course, if you have anything more to learn, I'm sure the IAG is very proud, and we as a faculty with all our faculty friends, we came out with the art and science of endoscopy, colonoscopy books, and we are updating them. And we also have some master classes, IAGS YouTube channels, And prime time, all these things are available on the net for you to go through anytime, because we always feel today you may be a trainee, but tomorrow you're all like me, like a trainer. For that, good luck all of you. Thank you. Nice seeing you all today.
Thank you, Mr. President, sir. Such a wonderful disposition. I'm already feeling that I can do colonoscopy tomorrow.
Thank you. That's
yeah. Thank you for covering it very crisply and telling us all the tricks and the tips, which comes obviously from experience of years and years together and creating complications and managing them and learning the wisdom and giving it to us. Thank you very much, and I will hand over the mic to our convener, Dr. Kanagvel, and then to our secretary, Dr. Satish Mita.
Thank you.
It's been a lot of learning today on either ends, one on minimal invasive rectopexies and then later on colonoscopy. I'm sure the audience would have had a robust learning for the past 1 hour. And friends, all good things have to come to an end. Can we have the honor of inviting the National Secretary, Mida sir, to propose out of thanks?
Thank you, Dr. Kanagvel. And so it was a great learning day for all of us with a good exposition on minimal invasive surgery in rectal prolapse by our friend from Singapore, Dr. Surendra Mantu. And as usual, our president presented good tips on colonoscopy. We know that colonoscopy has a great longer learning curve, and even sometimes experts are stuck. So it's an ongoing process, but we have to master this technique. And IAGS has been promoting surgeons to learn endoscopy as well as colonoscopy, and even go higher in the ladder to learn advanced procedures like ERCP and EUS in coming days. So thank you both the speakers. Thank Dr. Deep Goyal for moderating the sessions. Thank you, Dr. Kanagvel, the convener, for planning the prime time and giving us always new recipe in an academic form. Thank you, Team Doc Plus, for arranging this show. Thank you, all viewers. Good night, everybody. Thanks.
Thank you, Professor Mida. And we have something very exciting coming up. Our president has permitted us to go off the shores to have the surgical education in the limelight. So the roles of the societies and institutions in propagating the minimal invasive surgery training, that's going to be the event. So look forward for more information once we have clear confirmation from the international bodies. So without much ado, we call this session a close. And I also personally thank the team of Doc Plexus, Swapnil, Madhu, Sital, everyone who has been working along with us since the time of inception of the prime time. IAGS is ever indebted to them for giving a flawless platform. And I thank President and Secretary for permitting us to continue with program after program. Thanks, Deep, and thanks, dear friends in India and off the India. And I'm sure there are colleagues joined from Singapore and other parts of the world. Thank you for joining us. IAGS is a robust body. We look forward for more robust academics with you. Good night. Thank you very much.
Thank you. Good night.
Good night. Bye. Bye.